Welcome to all of you to our webinar, Measles in America, Causes, Risks, and Responses. My name is William Moss, and I'm a professor here at the Johns Hopkins Bloomberg School of Public Health, and as Tori said, the executive director of the International Vaccine Access Center. It's my great pleasure to moderate this panel today. We have three very distinguished guests with us today when we're going to talk about the measles outbreaks here in the United States. As of Friday, the Centers for Disease Control and Prevention reported 884 measles cases across 30 jurisdictions, with cases distributed across a wide age ranges, indicating that these outbreaks have been years in the making. About 11% of cases have been hospitalized, and we've had 3 deaths here in the United States attributable to measles. And very importantly, 97% of cases were either unvaccinated or had unknown vaccination status. We're not yet at the 2019 level, where 1,274 measles cases were reported throughout that entire year, just before the COVID pandemic. But we're on track, and we're not seeing a decrease in the rate of measles cases here in the United States, and we have the potential to lose our measles elimination status should transmission exceed 12 months. So we're going to have presentations by each of our 3 speakers. I will give a short biography of each of our speakers, and then we'll start. So Dr. Walt Orenstein is a professor emeritus of medicine, epidemiology, global health, and pediatrics at Emory University. From 2008 through 2011, Dr. Orenstein was deputy director for immunization programs at the Bill and Melinda Gates Foundation, where he focused on polio eradication, measles control, and improving routine immunization programs. Prior to 2004, Dr. Orenstein worked for 26 years in the immunization program at the Centers for Disease Control and Prevention, and specifically from 1988 to 2004, he was the director of the United States Immunization Program, where he successfully developed, promoted, facilitated, and expanded new vaccination strategies to enhance disease prevention. And I know, Walt, measles is the disease you love to hate. Our second speaker is Dr. Michael Mina, who's an epidemiologist, immunologist, and physician whose work bridges engineering, mathematics, and biology to advance public health. His research spans synthetic biology for immune monitoring, the population impacts of vaccines and infections, and diagnostic testing for epidemic threats. He is a recognized global leader in pathogen diagnostics and regularly advises U.S. and international health agencies on vaccines, immunity, and public health strategies. Dr. Mina was previously an assistant professor at the Harvard T.H. Chan School of Public Health and associate medical director of clinical microbiology at Brigham and Women's Hospital. He also led the Broad Institute COVID-19 testing platform and led the Biden administration's home test to treat program, and worked with the administration and NIH to create and lead the COVID-19 rebound cohort study. He now serves as a chief scientific or medical officer and scientific advisor across biotech and life science companies, from startups to Fortune 10 companies. And very importantly for our discussion today, Michael was the lead author on 2 papers in Science that evaluated the duration of immune suppression following measles and describing the immune amnesia. Our last speaker is Dr. Daniel Solomon, who's a professor in the Department of International Health here at the Johns Hopkins Bloomberg School of Public Health and is the director of the Institute for Vaccine Safety. His work has focused on post-licensure vaccine safety and the factors associated with parental decisions to vaccinate or not vaccinate their children. Previously, Dr. Solomon served as the director of vaccine safety at the National Vaccine Program Office, where he was responsible for overseeing and coordinating federal vaccine safety initiatives. At the end of the presentation, we'll have time for questions, but we're going to start with Dr. Orenstein, who's going to give us an overview of the history and purpose of vaccine mandates. Walt, over to you.
Thank you very much. Again, I'm going to talk, as Dan said, on the immunization mandates. Can I have the next slide, please? when we talk about a disease like measles, getting high coverage not only protects the individuals vaccinated, but protects the community. And what you can see here is a diagram showing on A, when you have susceptibles, you get a transmitting case. Then that transmitting case infects susceptibles, the light blues. They became ill and they start infecting other susceptibles. When you have high immunity in the community, the likelihood that a transmitting case will come in contact with a susceptible individual is markedly reduced, and you break the chains of transmission. And mandates are designed not only to protect the individual, but protect the community. I like to use community protection, others say community immunity, but the bottom line is getting vaccination levels high is good for the vaccinees, but it's also good for people who have legitimate medical contraindications and can't get vaccinated. It's good for people who have compromised immune systems and can't make a good immune response. And it's good for vaccinees because even though 2 doses of measles-containing vaccines at our recommended schedule is about 97% effective, it's about 3% ineffective. How are those people are protected? They're protected if they're not exposed. Next slide, please. This is one of the first areas of mandates. We do not have a United States mandate. It probably would be good from a public health point of view, but I don't think we'd ever gotten it if we had to do that from a political point of view. So we have states that started. And this is an example of an investigation in the 1970s at a measles outbreak in Texarkana, Texas. And what you can see here on the right is the Arkansas part, and very few measles cases. In the Texas part, loads of measles cases, showing how vaccines can have, and mandates can have, a major impact on measles for all. Next slide, please. What really made a big difference was 1977. An outbreak of measles was detected in Los Angeles County in mid-January. It continued to spread, and despite the fact that they made vaccine very accessible with clinics and schools, et cetera, there was still plenty of cases, several deaths, number of encephalitis cases, multiple pneumonia cases, and hospitalizations. And Shirley Fannin, who was director of the Communicable Disease Unit at LA County Health Department, said she was going to use our powers to exclude children from school if they didn't get vaccinated by May. And what she did is she held clinics in the schools, et cetera. And then by May, when this went into effect, about 50,000 kids still didn't have evidence of immunity, and she excluded 50,000 kids from school. Many of them actually were vaccinated. They just didn't have their records in. They came back, but they had to have their records. And this became the way we controlled measles outbreaks. And it didn't take long to realize that we should be in the business of preventing outbreaks rather than controlling outbreaks. And no shots, no school became the view. Next slide, please. And what we did is we got a presidential initiative in the Carter administration to focus on childhood immunization. And the major focus was getting every state to enact comprehensive school laws from kindergarten through 12th grade. And this just shows you early on, before the initiative, 6 states with laws versus other states. They had equal in 75, 76. By 77, they had reduced their measles incidence more than 50%, and by 1978, more than 90%. And this was very helpful. I remember when I was director of the U.S. Immunization Program, testifying before the Florida legislature, showing them the benefits and impacts of mandates. Next slide, please. So why school children are vulnerable? Children may not like to share their toys, but they sure are happy to share their germs. And there is legal precedent that parents patria, I may be mispronouncing it, but basically states have the right to protect children even if the parents object. Next slide, please. And schools are a shared environment, and there are loads of kids who can't be vaccinated, as well as loads of kids who should and can be vaccinated. Next slide, please. School mandates are effective. I showed you some of the data. Next slide, please. And it's an important consequence, but also the important thing is mandates help bring us in control of many vaccine preventable diseases, because almost all mandates do include many more vaccines than measles vaccine. Next slide, please. Now, the big opposition we're seeing from the anti-vaccine groups has changed from allegation of safety concerns, which you could bring some science to allegations, it's my child's body, my choice, the government can't tell me what to do. But that has to be balanced against the other family's interests, children's rights to be protected, and public health to protect our communities and other communities to which you can transmit the virus to. Next slide, please. So what is the basic framework, and is it legal? And there have been numerous attempts to overturn vaccine mandates. Vaccine mandates have started as early as the 1850s. In a very famous case before the Supreme Court in 1905, Jacobson versus Massachusetts was actually an adult who didn't want to get smallpox vaccine. And the Supreme Court ruled, yes, the state had the right to require that. Next slide, please. In Zuck versus King, similar legal issues. This was in more school-age children, but again, there is legal framework for requiring vaccinations, at least to date. Next slide, please. State mandates may vary. Next, and this is just where you can get what vaccines are required. Most of them cover the whole schedule, but they vary in terms of how they're done. Next slide, please. And most of them cover both public and private schools. Homeschooling is not as clear because it's difficult to enforce, but may do it. And then the vast majority include both daycare and school. Next slide, please. These are slides from the Association of Immunization Managers, just reinforcing that mandates are effective tools in high immunization coverage induction, as well as preventing disease. They're most acceptable when public trust and provider knowledge and public health support is there. When I was director of the U.S. Immunization Program, my director of communications said you need the right message delivered by the right messenger through the right communications channel, and we need to build that in. And it's easiest to do, obviously, when you already are starting with high coverage rates. Next slide, please. Exemptions are the major now issue. The exemptions are in all states and for medical reasons. But the other two types of exemptions vary. One type is religious exemptions. The other is personal belief exemptions. And there is where there are problems. There are 5 states that only allow medical exemptions, but many states allow religious and or personal belief. And that leads to outbreaks because it can be misleading to see high overall coverage, but if you have communities with substantial numbers of susceptibles, you can still get outbreaks even though your statewide immunization coverage is very high. In fact, the last polio outbreak in the United States was in 1979 in the Amish community, and there were very high coverage levels, but not in that community. Next slide, please. And these are some older data, but showing the effectiveness. Exemptors in this study in 1999 were 35 times more likely to contract measles. Another study showed they were 22 times more likely and 6 times more likely to acquire pertussis or whooping cough. Another one in 2009, 23-fold higher risk for pertussis. Another one even chickenpox. The bottom line is those children who are exempted and are in schools are at higher risk of getting infected, infecting each other, but also potentially infecting vaccinees who didn't make a protective immune response, as well as people not eligible for vaccination who had true medical contraindications. Next slide, please. And the issue is, again, just saying the biggest one that has raised concerns is the personal and philosophical belief exemptions. And that led states like California to eliminate that exemption because they were seeing problems. And whooping cough is one, measles is another. And the problems we're facing now is so many more people wanting these exemptions. And one of the things from a public health point of view is we need to find a way to either change the laws or at least educate these people that why it's so important to get their kids vaccinated. Vaccine hesitancy is, as I'm sure everybody on this call knows, is becoming a bigger and bigger problem. Next slide, please. So in conclusion, there are 4 messages. 1, school and daycare laws have played a major role in eliminating measles transmission in the United States. We have now gone almost a quarter century without endemic circulating measles, defined as circulation for at least a year. Strict enforcement is critical to achieving high immunization coverage and exclusion of kids who don't have or don't meet the requirements. The ease of getting an exemption, particularly a personal belief exemption, can increase susceptibility and is playing a role in some of our large measles outbreaks. And again, we need to remember when we talk about laws is they are not just about protecting the individual. They are about protecting the community, enhancing the overall health of our country. Thank you.
Great. Thank you very much, Walt, for taking us through the legal aspects and social aspects of the school entry vaccination requirements and the real importance of communicating the value of vaccination to communities. We're going to go next to Dr. Michael Mina, who's going to talk to us about some of the consequences of measles, particularly focusing on immune amnesia and other potential long-term impacts of measles outbreaks. Dr. Mina.
Great. So thank you very much for having me here. I'm Michael Mina. I'm going to be talking about measles immune amnesia and for the discovery and what it means for us both in this outbreak, but more globally as well. So first, to motivate this discussion is that in the past, where measles vaccines have been rolled out into new regions of the world, we've generally seen substantial reductions in all-cause childhood mortality. The reductions have been so great that they can't be easily attributed to just the reduction in measles-associated case mortality alone. And so that on the left is one study that was in MATLAB Bangladesh, and on the right you just see a forest plot from WHO demonstrating that this observation has been seen many times over. That when we roll out a new measles vaccine to a community that had endemic measles, without any vaccination, we see these large changes. So the hypothesis that there's one hypothesis that while the measles vaccine might have a direct benefit, that in terms of non-specific immune priming, that if you get a vaccine for measles, it somehow elicits sort of a strong immune defense that's very broad and will protect you against other infectious diseases as well, and therefore reduce all-cause mortality. The other hypothesis is that there's an indirect effect of the measles vaccine, and that when we roll out a measles vaccine, it actually uncovers a previously sort of before undetected long-term immune problem associated with measles, that when a child or an individual gets measles, maybe it somehow damages their long-term immune defenses, which could increase all-cause mortality or create a baseline of all-cause mortality. And when you then go into a community and you vaccinate against measles, you reduce the measles down, and therefore you reduce the long-term immune consequences of measles. and you see a drop in all-cause mortality. And so this was the hypothesis that back in 2013, myself and Brian Grenfell, Rick DeSwart, Diane Griffin set out to try to understand. So we looked at data from England and Wales to start. I won't go through all of the details of this. I can point folks to the papers, but suffice it to say that we used population level data. We looked at annual measles cases. And the first question we asked simply was, does the amount of measles at any given time correlate well or predict the amount of non-measles deaths that are going to happen to kids in that community? And the short answer was not really. There was some correlation, but it might have been driven by time and things like that. What you can see on the left is measles cases are biannual. You see in the dotted line there, that's the measles cases from year to year going up and down. And you really don't see too strong of a correlation with that black line, which is non-measles deaths. On the right, you see if you just focus on the blue curve on the right, that's just the correlation between measles incidence and deaths. So there's not too much. But we asked the question, well, what if the consequences of measles was longer? What if it wasn't just the number of cases in 1952 predicted the amount of non-measles deaths in 1952, but rather what if it was the aggregate of the number of cases in 1951, 1950, and 1949, as an example, would predict how much mortality might happen in 1952, implying a long-term effect of measles at a community level amongst individuals getting infected. So we asked this question, and we took a simple model of just aggregating cases, essentially. We said, okay, what if the duration of measles problems associated with getting measles on your immune system actually extended not just for the few weeks of acute infection, and not just maybe for 3 months, but maybe for a couple of years. And so we asked, what's the duration of the immune effects? And if we assume different durations of effects, does the accumulated cases of measles over that period of time effectively predict the non-measles mortality? So I'll jump to the chase by showing this video here. And what I want you to look at primarily is on this right side graph. The blue line there is the prediction of non-measles mortality being predicted only on measles cases alone. So does measles predict non-measles mortality? And what you can see, and in the dotted line on the right, is the amount of non-measles mortality. It's infectious disease deaths of kids. So what you can see is there's really no good prediction. The blue line does not look like the black line. But if we assume that maybe the effects of measles last longer, we get a video that looks like this. And what you end up seeing over time, and I'll stop this video right at its peak. What you can see here, if you stop it at the peak, it actually, the two lines end up being strikingly similar, where the cumulative measles incidence, when we assume that measles effects, if you will, last for 27 or 30 months, it predicts and explains almost all of the variation from year to year in non-measles infectious disease deaths. You could see the correlation on the left side, very strong correlation on the right side. You could see prediction. And that red line on the right side is actually an out-of-sample prediction, where we actually fit it based on all the pre-vaccine era. And then we still looked at post out of sample, and we could still get a very strong prediction where essentially measles cases alone can predict the dynamics of non-measles mortality. And so this was the UK, and we can do the same thing in the US, and I'll just show a similar video. And again, if you look at this middle chart with the blue line, it starts to match remarkably closely with the non-measles infectious disease deaths from the 1940s to the 1970s across the US, implying, and again, we got the same duration as well, of around 27, 28, 30 months. So together, this implies that maybe there's a 30-month or so effect of measles, where measles maybe harms your immune system. It takes, on average, kids who get measles about 30 months to recover. During that period of time, they're at higher risk for disease in general. So we sought to identify whether this was, really happening immunologically, and could we find any data for it? So first off, there's terrific animal data to demonstrate that, in fact, Measles does destroy immune memory cells. In 2000, the measles virus receptor was recognized to be CD150 or SLAM, which exists in very high levels on immune memory cells. So that means when a measles virus gets brought into the body through the dendritic cells, it goes to town and destroys our lymphoid tissue, specifically destroying, feeding on the cells that hold our immunological memory. So we can see this is just green fluorescent, essentially measles viruses that are fluorescing green inside of a macaque or a ferret. And what we can see is it just lights up the immunological memory compartments. And everywhere there's green is an immune cell, whereas the virus is destroying, and these tend to happen to be immunological compartments. So the hypothesis is then that measles gets into the body, it destroys your immunological memory. You get this big rebound of cells, most of which are measles virus specific cells or some bystander amplification. And then the question is, well, what happens to your immune memory that you had before you got measles? And the question then is, do you have to build it back? Maybe over years, you have a nice pool of immune memory cells that you develop from your first, second, third, fourth, fifth year of life. You then get measles at age 6. It destroys some of your immunological repertoire. Then you have to build back and chip away at it and start building back your immune repertoire. So we sought to ask the question, does this happen? Do we actually see a large reduction in our measles, in our immunological repertoire after people get measles? And so to look at this, we worked with a wonderful colleague, Rick de Swart, who in the Netherlands had the terrific idea to identify communities that had very low vaccination rates, went into those communities, asked if he could draw blood from children, just in case there was a measles outbreak in that community later on. And this was a time when there was circulating virus happening nearby. And so unsurprisingly, measles got into this community and infected around 100 kids. And he went back into that community and drew blood from these children again. So now we had a pre and a post blood sample to profile and look at what did measles do to these children's immune repertoires, their immune memory. And we used a tool called VirScan, which was initially developed by Steve Elledge. I worked in his lab for a few years to essentially get the tool operational in a way that we could start to use it towards these questions. And essentially what it is, it's a tool that allows us to profile and measure immune products called antibodies at scale. And so we're able to take a single drop of blood and measure the antibody repertoire of every known pathogen to infect humans in any given blood sample. And so essentially it's like a massive antibody test that gives you titers or antibody titers at the epitope level for hundreds of pathogens. We applied it to these kids who got measles. And what you can see, it's a little bit hard to see here, I'll show it better in the next slides, is that on the left, each column is a kid, each row is a different pathogen, and the color is what was the change in the antibody level. But you can see on the right, these are all the children, that red box, that got measles. On the left of that box are children who just didn't get measles, or adults in different control groups, and some who got vaccinated. There's no real solid blue or red on the left side. On the right side, we can see that the color is primarily blue. Kind of got to squint in this particular format to see it. But in general, we saw this large reduction in antibody titers. If we look at a little cleaner version, what we can see is that amongst the kids, if we look at what fraction of antibodies persisted after they got measles, we actually see that although controls they retain about 90% of their antibody repertoire. So you or I or anyone, in general, if we were to take our blood sample today and a little bit later, we would retain around 80 or 90% of our repertoire from time point A to time point B 8 months later. The measles infected kids, though, lost tremendous amounts of their antibody repertoire. Sometimes 50 or 60% of their immunological repertoire was lost in the months following measles. We did the same study in monkeys, a little cleaner study. We gave monkeys macaques. This was with Diane's group, Diane Griffin, who was at Hopkins. We infected macaques and looked at what level of their immunological repertoire persisted after they got measles, and saw very similar results, around 50% loss in their immune memory. And so what this all tells us is that measles deletes previously acquired immune memory, which we deem immunological amnesia. And this can explain these population level findings of large reductions in mortality when measles vaccines were introduced, together suggesting that measles may have been associated with as much as 50% of all childhood infectious disease deaths in the past. And therefore, measles vaccines and elimination have broad benefits by removing measles and removing this immune amnesia, effectively preserving immunity at a population scale. Thank you.
Great. Thank you very much, Dr. Mina. And, so we've heard from Dr. Ornstein how the value of the school entry requirements and how those help lead to measles elimination here in the United States. We've now heard from Dr. Mina the consequences of measles outbreaks and the long-term consequences on the immune system and immunologic memory. We're now going to go to Dr. Dan Salmon, who's going to tell us about how vaccine hesitancy contributes to ongoing measles outbreaks and strategies to increase vaccine uptake. Dr. Salmon.
Well, thank you for the opportunity to share this. I have to say those were two great presentations, and Michael, had a pleasure of reading your science papers and enjoyed watching you present it. So, this is what measles looks like over the past 25 years in the US. These are the most recent data from CDC, and you really see what was happening before the pandemic, where we were very close to losing our measles elimination status. And, as we shut down the world and limited social interactions for COVID, we saw a clear drop in measles, and it's clearly coming back now. If you look at the cases by vaccine status, and Dr. Moss, I think, mentioned this early on, these data are a bit older, but you see that predominantly cases are among unvaccinated person, some unknown, and just a few that are vaccinated because the vaccine is not perfectly effective. When looking at MMR vaccine coverage, and this is from 6 states, you see a drop since the pandemic. And, we're really looking for measles vaccine coverage to be around 95% to provide adequate protection. But, that's adequate, that's immunization coverage across the board. And in many ways, vaccine refusal and the contribution to outbreaks is a local issue. This is the percent of kindergartners vaccinated with MMR. And you see a fair amount of variability across the country by state, and many states that are well below the 95% target, which is needed to really control measles. But that camouflages local rates. So this is the percent of kindergartners with an exemption in Michigan. It's recent data. Many states don't have this available. I'm showing the Michigan data because it was. But you can see that while coverage is fairly high across the state, within communities, and this is by county, you see much higher refusal rates. And if one were to drill down within a county, you would see even more geographical clustering. And importantly, you have geographical clustering, but you also have social clustering. And in fact, the ongoing measles outbreak now really started in a group that was both socially and geographically clustered, as we've seen in many outbreaks, right? Typically, you see someone leaving the US and going someplace where there's measles and bringing it back, or someone coming from one of those countries, which is most commonly Europe. There's lots of measles in lots of the world, but the most travel we see in importations are coming from Europe. Walt mentioned this study earlier we did about 25 years ago, and we found that children that had an exemption to school immunization requirements were 22 to 35 times more likely to contract measles compared to vaccinated children. And, this gets at the individual risk of vaccine exemptors. We also did some modeling and to look at the community risk. And it was interesting because a lot of these data were during the measles resurgence, and our modeling didn't converge. We didn't have outbreaks until we started to work in the social and the geographical clustering of vaccine refusal. I'll also mention that in these studies, we compared the incidence of measles among children who were vaccinated versus children that had an exemption. And we assumed that if a child was exempt at all, that they were exempt from measles, which was an imperfect assumption, but it was all the data we had. Since then, we conducted studies that found about 75% of children with an exemption, in fact, had a measles vaccine. So that would make these relative risks about 4 times higher. So this really gets at the individual risks of unvaccinated children. I mentioned in Europe that a lot of the importations are coming from Europe, and this is measles since 2013 to March 2025 in Europe. You also see that there was a real drop-off during COVID, but that it's coming back, although here we see cases by country and the overall number of cases in Europe. And, they obviously have a much bigger issue with measles than we do in the US right now. And this really just exemplifies the potential for an international importation. A breakdown in Europe of vaccine or measles cases by vaccine status. And you see that, again, the majority of these people with measles are people that were unvaccinated. And just to make note, there's a lot of attention to measles and vaccine refusal, but measles is an easy disease to study in this way because the vaccine is so very effective, and we don't have a lot of measles in the US, but the opportunity for importation. But pertussis is another disease one would want to think about, because it is around. There's a lot more opportunity for a susceptible child to get pertussis. It's not as clean of a picture because the vaccine is not as effective, or the vaccines, and waning immunity. But this is a study we conducted in Michigan looking at the spatial temporal clustering of vaccine exemptions, finding if you lived in an exemption cluster, you were about 3 times as likely to also be in a pertussis cluster. So, what are some strategies to increase vaccine uptake? And I only have 10 minutes, so I'm going to keep this brief. But I'd throw out a few ideas, and it's not specific to measles. I think it's more broad about other childhood and vaccines more broadly. But first, we need to meet people where they are. Yelling and screaming and calling people names is not going to get us anywhere. And we need to understand what people's concerns are. We need to give them the best possible evidence in a way which is understandable to them, and really help them make informed decisions. And to do that, we need to meet people where they are. We need a robust and a responsive vaccine safety system. And, just to be clear, vaccines are very safe. Measles vaccine has a very good safety record. And a lot is done in the US and globally in vaccine safety science. With that said, it's been chronically underfunded, and often the concerns of the public take a very long time to be addressed through science. And I think this is a place that we can do better. Healthcare providers have a critical role. If you talk to people, to parents, to the public more broadly, whether they're vaccinated or not vaccinated or partially vaccinated, they turn to their healthcare provider. It's the most valuable source for people, whatever their vaccine decision. And we need to make sure that clinicians have the information, the tools they need to really make the conversations with the parents, with the public, as useful as possible. We offer some of these tools on our website. If you go to vaccinesafety.edu, you'll find systematic reviews of more than 50 vaccine safety topics to really provide clinicians and the public information they need, though it's geared more towards clinicians. We also have a website, Let's Talk Shots, and this is intended for the public. So it's the same underlying data and information, but presented in a manner that will be more useful to the public. So, for example, when we talk about the risks of disease or the benefits of vaccination or the risks of vaccination, we visually depict these using things like football stadiums. So let me end there, and I'm happy to participate in the conversation.
Great. Thank you very much, Dr. Salman. So we encourage our audience to put questions in the Q&A. We do have one question, and Dr. Minna, this will be for you, and it's from Ashok, drawing out kind of a really important potential policy and implications from the science and evidence you presented on immunologic amnesia, and that is whether children should be revaccinated after measles. And do you want to reflect on that, and what is your take on whether or not that should be a recommendation?
Yeah, it's actually it's the population data that we put together that I presented was actually the first of that series of papers, and this question was actually posed to us by some folks at the WHO, which actually led to us doing the immunological studies. And the reality is, the immunological amnesia is varied across people. I think it would be hard to make a blanket statement that we should run and give everyone, PCV13 and HIB and things like that, and revaccinate them right away after they get measles. In particular, it's a little bit of a catch-22. The folks who are getting measles are obviously the folks who haven't yet necessarily gotten all their vaccines, so it's kind of pouring salt in the wound a bit. That said, I think that it's worth the discussion to be had, in particular in areas where measles remains endemic, where we do have tools and maybe kids haven't yet been fully vaccinated. I think it's worth thinking about what are the ramifications of this, and are there ways to mitigate these long-term consequences. Some children may do just fine and may not lose, nobody's losing all of their immune memory, and it turns out immune memory is quite good at having redundancy. But obviously some kids don't do fine as well. And so I don't think there's a one size fits all, and I think it would take some new assays and some new approaches to really be able to think through what are the policy implications for this.
Great, thank you. And I acknowledge, yeah, it's a complicated issue. We have a question, and I could open this to anyone, but if a healthcare worker received 2 doses of measles vaccine during childhood, do they need additional dose of measles vaccine? I don't know, Walter.
The CDC, basically, the vast majority of people who've had 2 doses of measles-containing vaccine appear to have very long-term, probably lifelong immunity. There is a very small proportion that may have immunity waning, but that's a very, very small proportion. And so at this point, if you have 2 recommended doses at the appropriate ages, then I don't think that person needs another dose.
And I would say to that point, what's really nice here is, nice is a weird way to term it, but we have real world data in the United States right now reinforcing what Walt just said. We don't see older individuals. In fact, it's probably the middle-aged individuals who have the lowest antibody titers because they didn't get naturally boosted over and over and over as kids. So the proof is in the pudding, though. We're not seeing individuals in their 40s, 50s, 60s, 70s in Texas who were vaccinated, getting or infected, as kids getting measles. And so there's no signal right now that there's any real need.
Yeah. Another vaccination question is, should we be vaccinating children at 6 months instead of 12 months of age? And are there downsides to vaccinating at a younger age? Walt, do you want to?
Okay, yeah, that's actually being considered by the World Health Organization as well. The big issue clearly is if we can get vaccination into the older kids, the likelihood of exposure is not a problem. There is some concern about vaccination at very young ages, leading to what has been called the blunting of the immune response, that when you vaccinate kids vaccinated very early in life, the titers that they achieve can be lower than the titers of people who receive that dose for the first time. I think the big issue is whether that child is at significant risk of measles exposure, so that could be considered for travel, or if you're in a community where there's an ongoing measles outbreak, but not on a routine basis, and certainly not universally in the United States for that time. I don't know, Bill or Michael or Dan, if you have any different thoughts.
I agree fully. Yeah.
The CDC does recommend, vaccination younger, between 6 and 11 months of age here in the United States for children who are traveling internationally. And I think that would apply for children kind of in an active outbreak setting.
No, I completely agree. That's where there's the risk of getting measles. Pardon my language, trumps the risk of any vaccination. So certainly for that, and that should be counted as MMR 0.
Yes.
And that child, when becomes age eligible for MMR 1 and MMR 2, should get both of those doses.
Yeah. Maybe we'll take one more measles vaccination question. So should adults vaccinated prior to the rollout of MMR vaccine consider a measles booster if they're living in a measles endemic area? And so go.
Is that asking adults who did not get their measles, who were naturally infected with measles? I take it that's what that question is asking. Does everyone agree?
I think so, or before. Yeah. The question's around before MMR, but
before, maybe it was a single dose vaccine. I would argue, and Walt, I'd be interested in your take, but the reality is actually people who were vaccinated, even with a single dose, years ago, they were likely actually exposed, multiple times. And what we see in the blood supply, for example, is that older individuals who maybe got single dose, who maybe got no doses but were infected, actually have persistently elevated titers relative to somebody born in the early 80s, who really didn't ever see measles, as an example. So I don't think that there's a reason to have greater concern.
Yeah, I would agree.
I think particularly for adults born in 1957 or before 1957, almost all would have had natural infection, and clearly natural infection is associated with lifetime immunity. I think there has been some concern adults born in 63 to 68, I think, when we had 2 vaccines available, the live attenuated vaccines plus an inactivated vaccine, which was not effective and also could result in what was called atypical measles and immunity enhanced case of measles. So a number of them potentially can consider vaccination, but for the most part, the big issue is, as Michael was saying, is people more recently.
Yes. Dan, maybe a set of questions for you. What do you expect to see over the next year or beyond regarding measles in the United States? And I know you don't like to predict, but maybe your best guess is there. And then what are the implications of losing the measles elimination status here in the United States?
Yeah, where Bill's musing over our conversation before we it's always risky to predict things. And I think if you look at people that have tried to predict the flu, it hasn't always worked out well for them. But measles is a much more stable virus. I mean, my gestalt is that had we not shut down for COVID, we probably would have lost measles elimination status, during that period. And frankly, I'm quite worried. And Bill or Walt or others may comment about broader implications of elimination status, but I think it really speaks to where we are in controlling or not controlling measles. And I don't know that having the elimination status is necessarily what matters most. I mean, the 2 children that died from measles didn't benefit from our elimination status. But I think what we need to worry about is really widespread community transmission. And, and from an infectious disease standpoint, once we're at a point of widespread community transmission, it's very hard to come back. And we could see substantial morbidity and mortality. So I'm quite worried. I'm quite worried that we're at a place where there's just an awful lot of tinder and lots of sparks, and we could really see widespread community transmission.
I completely agree. I mean, to me, it doesn't matter if you've got spread through 364 days and terminated at 365 is you lose your status. I think the big issue is if we have sustained transmission in the United States, we're going to get many more cases of measles, hospitalizations, deaths, and other problems. So to me, that's the big concern is interrupting transmission is a benefit to the community and reduces the risk of large outbreaks.
Yeah. Maybe a question for both Dan and Walt. With high rates of exemptions by parents in preschools, can't the government reconsider amending its laws to ensure reduction in vaccine hesitancy? So what would it take to actually modify laws at the state level to reduce the numbers of exemptions?
Yeah, I mean, I think, Dr. Moss hit this a bit earlier, as did Dr. Ornstein. Firstly, these are state laws, so it's up to the states. And we've seen in studies prior to COVID that having exemptions that are more difficult result in lower rates of exemptions and lower rates of pertussis as well. So I think there's certainly some room for improvement there, but I don't think we're going to mandate our way through this problem. And in fact, becoming more draconian with mandates, I think really risks further alienating and frustrating more and more parents. And, if you look at my slides, I didn't include making exemptions more strict. Instead, I said meeting parents where they are. I don't think it's a panacea. I think Walt provides very compelling data showing that mandates have really had a very positive impact on the health of children. But they also come at some limitation to parental autonomy. And I think they work well when most people want to get vaccinated. But when you're trying to force a vaccine upon parents, children who don't want the vaccine, it only makes things worse. So I don't think that my own opinion is in today's climate, making vaccine mandates more strict is likely to be beneficial. But I turn that over to you. Walt, maybe you have a different view.
Yeah, no, I would agree. I think the bigger issue would be investing in implementation science and implementation efforts. People often can invest in buying a dose of vaccine, but they don't invest in getting that vaccine dose out of the vial into the bodies of people for whom they're recommended. I think I mentioned already, providers who I've spoken about don't have the time, they feel, to deal with hesitant parents, and which may require a prolonged discussion. And we do have codes now for reimbursement for vaccine counseling when vaccines aren't given, but I don't know how many insurance plans actually cover that. Maybe Dan or others will know that, but I think we need to try and support that. And I think we need to look and support, how do we message this? There's a very famous study by Brendan Nyan, who was at Dartmouth at the time, looking at people who had resistant ideas about measles containing vaccines, and simply giving them the facts went the other way. And so we need to invest in trying to better understand how we overcome hesitancy and how we get, it was Dan who gave me that line that I love to use: vaccines don't save lives, vaccinations save lives. And I think we need to invest in how best to do that rather than making them hard. What could be done is, for example, to get an exemption, you have to sign something or read some material or given material about things. But I don't know if that will make a difference or not, but I think that could be one thing that could be done.
Yeah, I think historically, domestically, and globally, we've taken the approach that if we build them, will come. That if we make vaccines available that have been shown to be very safe and very effective, that if we eliminate or reduce costs as a barrier and try to create social norms, that we'll get there. And I think historically we've seen that'll get you a lot of the way. But we really need to rethink that paradigm because it's not working. It's not working as we see with measles. I mean, it works, it gets you a lot of the way, but it doesn't get you all the way there. And I think it's a really a rethinking of reframing vaccines to not just meet public health and clinical needs, but the needs of parents, the needs of patients. And that includes science and evidence, not just being done, but being delivered in a meaningful way. It's a complicated picture, but I don't think mandates are the solution at this point.
Dan, maybe we just have a few minutes left, but maybe I'll come back to you with a question, based on your presentation. And you mentioned, vaccine safety monitoring, and there's a lot of obviously public discussion around vaccine safety, and there will continue to be, and there should be. But what would be some ways that you would propose to make vaccine safety monitoring better?
Well, we have new opportunities, and I would say in three areas. One of the challenges we face broadly is that when you vaccinate a lot of people, bad things will happen by chance after vaccination. Or is it by chance, or is it actually causal? And that takes epidemiological studies, and it's done most effectively through large active surveillance systems linking healthcare databases. And there's huge opportunities domestically and globally in that space. And by doing careful studies using electronic health data, we can more quickly separate causal from coincidental. I think that's one area. Another area is to understand the biological mechanism of adverse reactions when they do occur. And as we understand disease pathologies of all sorts of diseases better, we can better understand the cause of adverse reactions and specifically genomics. Why is it 1 to 3 people per million will get Guillain-Barré syndrome after a flu vaccine, as an example? And it could just be random, but it's probably not. It's probably something to do with those people. And if we can understand the biological mechanism, if we can identify a genetic risk factor and then screen and contraindicate those people, we can reduce even rare adverse reactions. So I think that there are a lot of opportunities with new science, with big data, and we really need to leverage that. We need to do it, to identify and reduce adverse reactions when they occur, but also to provide the public reassurance that we're doing everything we can to make sure that vaccines are as safe as possible and used as safely as possible.
Great, thanks, Dan. And that's a great place to end our webinar. I want to thank all of you who joined us, and we reviewed in some depth measles in America, the causes, the risks, and responses. And I especially want to thank Dr. Walt Orenstein, Dr. Michael Minna, and Dr. Dan Solomon for their insights today. I realize we did not get to all the questions from you, but I hope you found this worthwhile, and we will make a recording available. Thanks to everyone.